Hello, my name is Mirrakhimov. I am the cardiac anesthesiologist at the University of Kentucky and also the PACU rotation director for our anesthesiology residents. Today, we'll be talking about postoperative nausea and vomiting, or PONV. I have no conflict of interest in regards to this presentation. So what is our agenda for today? We'll start by discussing the pathogenesis, followed by risk factors, preventive measures, management of breakthrough PONV, and we'll end with a couple of interesting cases. So the disclaimer for this one, the clinical case scenarios which we present are only for educational purposes. Any resemblance to real individuals or medical situations is purely coincidental. Do not use this information as a substitute for professional medical advice, diagnosis, or treatment, and always consult with a qualified healthcare provider regarding your specific medical concerns. The magnitude of the problem is unfortunately still quite big. The PONV is still a common occurrence after surgery, and a lot of our patients are still having it in the PACU and in the first 24 hours after discharge. Some consider PONV as potentially worse issue than pain. PONV has several potential negative impacts on our recovery process. For example, delayed discharge, risk of readmission, whether due to breakthrough symptoms or dehydration and acute kidney injury, wound dehiscence, such as in patients who have abdominal surgeries, risk of aspiration, and poor patient satisfaction. The pathogenesis of PONV can be simplified into three main components, such as central component, including cerebral cortex and brainstem, peripheral component, which we will include our GI system and vestibular system, and obviously medication and toxin component, which can affect both central and peripheral parts. On this slide, on this pictorial, you can see that the most important part of the brain, which kind of regulates different stimuli, is located in the medulla, or brainstem. The CPG, or central pattern generator, or also known as vomiting center, is located in the medulla. And it gets impulses and stimuli from different parts of the body, for example, from the cortical areas of the brain, which can be stimulated by emotions, fear, and anxiety around the surgery. Also, peripheral nervous system via substance P, neurokinin, and serotonin can impact the medulla centers. For example, in patients who have trauma to the stomach or blood aspirated either from trauma or injury or because of a surgical event, such as in patients who have transsphenoidal pituitary surgery, this can lead to stimulation of the medulla and eventually cause PONV. The vestibular system is also quite important. That is why patients who do have ear surgeries, especially children, have high risk of postoperative nausea and vomiting. Let's talk a little bit about neurotransmitters. Primarily, it is important for us to know which neurotransmitters and receptors are involved in the POV pathogenesis, because we'll be able to modulate those receptors. M1, or muscarinic receptors, H1, or histamine receptors, are predominantly located in the vestibular system. Serotonin, or 5-HT3 receptors, substance P, and neurokinin 1 receptors are predominantly located in the peripheral system, such as stomach or bowel, and dopamine 2 receptors, or D2 receptors, are predominantly located in the brainstem system. So what are the risk factors for postoperative nausea and vomiting in adults? We can break it down into preoperative, intraoperative, and postoperative. For preoperative, female gender, history of motion sickness, non-smoker or non-smoking status are considered to be risk factors. And they're highlighted in bold because they're the part of what's so-called APFL score for PONV. And again, we do not recommend you to start smoking just to decrease the risk of PONV. Some other risk factors in the preoperative part include history of pre-existing nausea and vomiting, previous PONV, age less than 50 years old, and history of chemotherapy-induced nausea and vomiting. For intraoperative factors, it's important to include general anesthesia, at least partly because we commonly utilize inhalational anesthetics to maintain anesthesia. Potentially, the longer the surgery, the higher risk of the PONV, and also abdominal surgeries, gynecological surgeries, and laparoscopic surgeries are considered to be associated with high risk of PONV. Medications are important to be aware of, both in the intraoperative as well as postoperative risk factors for nausea and vomiting. And again, most of will be talking about longer acting opioids, such as, for example, morphine. So what are the risk factors for children? And again, this is primarily an adult talk, but I think for the exam purposes, it's important for us to be aware. So again, we will break it down into three parts: preoperative, intraoperative, and postoperative. In preoperative, age of 3 years and older, previous history of PONV, history of motion sickness, and postpubertal female. For intraoperative risk factors, we include here surgeries lasting at least 30 minutes, strabismus surgery, ear surgery, ENT surgery such as adenal tonsillectomies, and use of inhalational anesthetics. And like in adults, the main risk factor for postoperative nausea and vomiting in the postoperative management part is use of longer acting opioids. So what are the tenets of prevention? So first of all, it's obviously important for us to understand what's the patient's risk of PONV by doing a good and thorough risk factor assessment. We review the previous anesthetic record or records and see what preventive strategies were utilized, whether they were successful or not. If possible, and there are no contraindication, consider liberal IV fluid therapy, which is defined typically as 15 to 30 cc's per kilogram of IV fluids during the surgery, and utilize multimodal pharmacoprevention. And again, if there is no major risk factors, again, use your clinical judgment whether you need to utilize any pharmacoprevention. In patients who have one or two risk factors, which will be the majority of our patients, consider utilization of at least 2 antiemetics plus minus regional anesthesia and TIVA with propofol or total intravenous anesthesia. In patients who have 3 or more risk factors, consider utilization of 3 different antiemetics. Strongly think about whether regional anesthesia is appropriate in a patient, whether it's a pure surgical block or analgesic block to decrease the amount of opioids the patient needs to take after the surgery, and consider total intravenous anesthesia with propofol. So here we'll start by talking and discussing different pharmacoclasses in regards to prevention and treatment of PONV. We'll start with glucocorticoids. Dexamethasone, which is the most commonly used agent for this reason. Typical dose of dexamethasone includes somewhere from 4 to 8 milligrams. It has delayed onset, which makes it unsuitable for acute management. That's why we typically utilize dexamethasone early in the induction period, so to give it enough time to start working towards the emergence process and recover in the PACU. So what are the potential concerns and side effects with glucocorticoids and dexamethasone in particular? Again, it does indeed increase your glucose, questionably leading to surgical site infections. However, a single dose of dexamethasone used for PONV prevention is unlikely to significantly impact this risk. Obviously, in certain patients, such as pediatric patients with blood or hematological malignancies, or certain adult patients with hematological malignancies, it can lead to what is called a tumor lysis syndrome and potentially severe and serious complication. So something to keep in mind. So the next group of medications we utilize in PONV prevention is anticholinergic group of medications. And what we typically use is scopolamine 1.5 milligram transdermal patch. And again, like dexamethasone, it has a delayed onset, so should be placed at least 2 hours before the start of anesthesia. It is recommended not to use in patients who have angle closure glaucoma. The side effects are usually mild and may include dry mouth, blurry vision, and delirium. The patients can typically keep the patch on for about 24 hours, and when they remove it, encourage them to wash their hands again before they potentially touch or rub their eyes, just to avoid the risk of blurry vision. Next, we'll talk about the working horse of PONV prevention and management, which is serotonin receptor antagonist group, or 5-HT3. And ondansetron, or commonly known as Zofran, is the workhorse of our PONV management. The typical dose is 4 milligrams. The onset is about 10 to 20 minutes, and it lasts for about 3 to 4 hours. The newer agent is polonosetron, and the typical dose is 0.075 milligrams IV. It has slightly slower onset of about 30 minutes, but it does last up to 72 hours potentially, making it a better agent for preventing delayed PONV. Again, very important to know that both of these agents tend to prolong QT interval on EKG and potentially predispose patients to certain arrhythmias. Neurokinin-1 receptor antagonists is a newer class of medications used for PONV management and prevention. It's important to counsel your female patients that it can lead to decreased efficacy of oral contraceptives. It has an onset of about 1 hour with peak effect of about 4 hours, and it does tend to last for up to 40 hours after the use, making it a nice option to utilize to prevent delayed PONV. The dosing is typically 40 milligrams PO preoperatively, or for the IV formulation is about 32 milligrams given over 30 seconds, and it does not prolong QTC interval. Next, we'll talk about antihistamines. And again, it's important to know that not only they block H1 receptors, they also block muscarinic receptors too, but maybe to a lesser extent. We'll talk about two agents here, diphenhydramine or Benadryl. The typical dose is 25 to 50 milligrams. The onset is relatively quick, within 30 minutes, and may last for 4 to 6 hours. A similar agent, which is D-methylhydronate, again, the typical dose is 50 milligrams. So the onset of action is within minutes, and it lasts for about 4 to 6 hours. Common side effects for these agents include sedation, dry mouth, urinary retention, delirium, and prolongation of the QTC interval on 12-lead EKG. The next group of medication which can be used in the management of PONV is phenothiazines. Two agents here, promethazine or Phenergan and prochlorperazine. Both of these agents tend to block dopamine 2 receptors, M1 and H1 receptors, with prochlorperazine being more selective for dopamine 2 receptors. They do have a relatively quick onset time of within 10 minutes and last up to 6 hours. These medications should not be used in patients who have Parkinson's disease. They do tend to prolong the QTC interval. They tend to cause sedation, with promethazine being more sedating agent than prochlorperazine. Another important thing about promethazine is that it can lead to severe soft tissue injury if extravasated when used through a questionable peripheral IV. Next agent we talk about is metoclopramide or Reglan. By itself, it's quite weak antiemetic. It tends to affect dopamine 2 receptors and also stimulates GI system and increases the response to acetylcholine. That's why it's a promotility or prokinetic agent. Typical dose is 25 to 50 milligrams, and consider giving this medication slowly to decrease the risk of possible complications. Its onset in about 5 minutes and lasts for up to 2 hours. Some of the adverse effects of these medications include extrapyramidal symptoms, hyperprolactinemia, which can manifest as decreased libido in men, or galactorrhea in females, CNS depression, and QTc prolongation. And like most medications which affect the dopamine 2 receptors or block those receptors, they should not be used in patients who have Parkinson's disease. Next group of medication is antipsychotics. And again, it doesn't mean to say that patients who have PONV are psychotic patients, but rather because these medications typically affect multiple receptors involved in the pathogenesis of PONV. That is why we use them. So we'll talk about two agents. The older agent, which is haloperidol, the typical dosing is 0.5 to 1 milligrams. It does block dopamine 2 receptors, but also it has some antagonistic effects on H1 and M1 receptors. The onset of action is about 10 minutes and it lasts up to 4 to 6 hours. It has a high risk of extrapyramidal symptoms. It does lead to sedation and also can prolong the QT interval. A newer agent, which is olanzapine, typical dose is 5 to 10 milligrams. It's slightly more selective for dopamine 2 receptors, but also can affect 5-hydroxytryptamine type 2, type 3 receptors, or serotonin type 2 and type 3 receptors, and it has a weak activity against H1 receptors. The onset again is about in 10 minutes, but it can last up to 30 hours. There's a similar risk profile to haloperidol, maybe with slightly lower risk of extrapyramidal symptoms. And again, we'll discuss some additional medications which affect dopamine 2 receptors, and one is amisulpride, and the second one is droperidol. The onset is relatively quick, and amisulpride can last up to 24 hours. And again, like any agent which blocks dopamine 2 receptors, it should be avoided in patients who have Parkinson's disease. It has a risk of extrapyramidal symptoms, hyperprolactinemia, and QTc prolongation. Since we mentioned the term extrapyramidal symptoms today, let's talk and discuss what they are. There are four main ones: tardive dyskinesia, akathisia, drug-induced Parkinsonism, and acute dystonia. They are all managed by stopping the offending medication, utilizing antihistamines or benzodiazepines. And again, I would encourage you to consult our services such as psychiatry or neurology to help us managing these patients. So let's talk about miscellaneous agents which can be utilized in management of PONV. Propofol, even in subhypnotic or subanesthetic doses, it does have significant antiemetic effect. Inhalation of isopropyl alcohol can help you in the rescue management of an unstable patient who is about to vomit. It is unclear whether medications such as midazolam or ketamine have any effect on the risk or prevention of PONV. So what is an approach to acute management of PONV? Like in any critical situation, it's important to assess the patient's stability and vital signs. Consider an alternative or concurrent diagnosis, such as, for example, inferior acute myocardial infarction presenting as nausea and vomiting, or acute pancreatitis mimicking PONV. Review the anesthetic record, with particular emphasis on intraoperative events, amount of IV fluid given, and antiemetic strategies. Consider using additional medications from a different class or classes if not contraindicated. So let's talk about the case. we have a case number 1. A 25-year-old non-smoking female is scheduled to undergo laparoscopic cholecystectomy. She reports that she did unfortunately experience significant PONV 3 years ago after her appendectomy. She does have a history of motion sickness, and her past medical and anesthetic history is otherwise unremarkable. She does not take any prescribed medication except over-the-counter ibuprofen. We were able to review her anesthetic history 3 years ago. It was an eventful GA with a tracheal tube. She was maintained with sevoflurane, and she received dexamethasone and ondansetron for prophylaxis. And here's a couple of questions. What is her PONV risk, and what is our preventive strategy? So case 1 continued. This patient has a very high risk of PONV. Next question is, can we do this surgery safely without general anesthesia? And the answer is no. The reason I put probably not here is because if you do literature search, you'll be able to find cases done under spinal or epidural anesthesia for laparoscopic surgeries. But again, that's probably not the standard of care in this country. So what we are going to do differently, we'll continue dexamethasone and ondansetron. We'll add scopolamine patch at least 2 hours before the surgery. We will consider utilizing TIVA with propofol, and do consider multimodal analgesia to decrease the amount of opioids we need to use to control her postoperative pain. Here's case number 2. You have a 27-year-old female who is morbidly obese with a BMI 41. She is scheduled to undergo laparoscopic cholecystectomy as well. She does not smoke and has significant motion sickness. She is otherwise healthy and doesn't take any medications. Because of her weight, she was seen at the preoperative clinic, and the preoperative clinic obtained a 12-lead ECG. So here is a patient 12-lead EKG. I'm going to leave this EKG here for a few seconds for you to review. And again, feel free to pause the video if you need more time to understand what's going on with this 12-lead EKG. So here are a few questions. What is the patient risk of PONV? What is our preventive strategy? And do we have any additional concerns? Again, this patient has a very high risk for postoperative nausea and vomiting. You probably cannot do this surgery safely without general anesthesia. And again, what does her 12-lead EKG show? So let's take a look and review this 12-lead EKG. Again, this is not a talk on how to interpret 12-lead EKG, but again here we can see that the QT interval seems to be quite prolonged. What we can do here is see the distance between the RR or the RR interval and see that the QT interval is more than 50% of the RR interval, suggesting that this patient has prolonged QTC syndrome. Whether it is acquired or congenital, it's beyond the scope of this talk. So it is important for us to understand which medications are safe to use in patients who have prolonged QT interval. And again, this includes scopolamine patch, dexamethasone, propofol, and aprepitant. So let's continue talking about this case. First, let's discuss our strategy. We'll utilize scopolamine patch at least 2 hours before the surgery. We will avoid volatile anesthetics, both for the QTC prolongation concerns as well as association with PONV. We will also avoid nitrous oxide for PONV risk. We will utilize TIVA instead and use propofol. We will also avoid any other medications which can prolong QTC interval, such as methadone and any other antiemetic medications which can prolong this interval. For example, ondansetron, which is a common medication we use for this reason, will be avoided. We will also treat and correct electrolyte abnormalities which can prolong the QTc interval, such as hyperkalemia, hypomagnesemia, and hypocalcemia. So in summary, PONV is quite common and is associated with increased morbidity. We need to utilize risk factor-based prevention strategies. We need to know our pharmacological options, their limitations, and contraindications. And again, it's important not to miss a concurrent or alternative diagnosis when dealing with PONV patients in the PACU. And again, thank you very much for your attention and good luck.